But we're moving on to our cure-based panel, which we do have an excellent panel. So Dr. Mark Atkinson, and I'll have the panelists just stay where they are, and then I'll call them up to go over their slides. Dr. Mark Atkinson comes from the University of Florida. You heard him referenced a lot yesterday in Aaron Kowalski's talk. He's probably one of the best type 1 diabetes researchers around. He has he runs basically a collaboration called InPod, which is samples of pancreatic tissue, basically. So if people with type 1 diabetes pass away for whatever reason, they donate their pancreases. And we can learn a ton from that, because we really have no way of looking at what's going on in the pancreas when people are walking around. But from these tissue samples, we've learned a ton. And I'm really excited to hear him talk about it. Dr. Matthias von Hereth is going to speak also. He's an immunologist that works here in town. I actually worked in his lab for a year before I went on faculty at UCSD. Does a lot of these cure-based therapies, immunology therapies. How can we preserve insulin production? How can we reverse type 1 diabetes? These are things that Mark and Matthias are going to talk about. David Winkler has basically founded a group called the Diabetes Research Connection, which is here in the area over there. That's, what's that? Exhibit Hall. And it's the concept of the Diabetes Research Connection is allowing people like yourselves to directly fund research projects that you might be interested in. So instead of donating to maybe different organizations who then give grant money, actually knowing projects and doing kind of crowdfunding, if you will, for these different projects. And then me. Kelly Close was supposed to be here. She had some family issues to attend to, so she's not going to make it. But I did want to start with me, because you guys might think that I'm the alcohol guy and this is what I do. But my day job is actually doing clinical research, so I actually do have a job. And so I wanted to talk a little bit about some of the research we're doing, and particularly a study that's been sponsored by a group called ViaCyte that a lot of you might have heard about. So I'm going to start with some slides, and then I'm going to have Mark come up, and Matthias and David go over their areas of research, and then hopefully we'll have times for questions, depending on how we're going. So what I'm talking about, this company called ViaCyte is something called, or a concept of islet cell encapsulation. So what does that mean? So I have a picture here showing this. So we all know that everybody here with type 1 diabetes, we don't have any beta cells or enough beta cells to basically make insulin. So wouldn't it be great if we could do an islet cell transplant, essentially? If I could, get islet cells from somebody else. The problem is, if somebody wanted to give me islet cells, my body would still recognize that those are foreign. They would attack and destroy those cells. And if I wanted to get a pancreas transplant or a kidney transplant, in order for that pancreas to survive, I would have to take a lot of immunosuppressive medications, which have a lot of side effects. They can cause infections, maybe cancers, and these kinds of things. So the concept with islet cell encapsulation is, what if we can take these islet cells and encapsulate them in some kind of device? And the idea with this device is it had holes poked in it, essentially, so that nutrients and glucose could get into the device. The beta cells or the islet cells could say, oh, the glucose is high, I'm going to secrete insulin or whatever hormones I need to, or glucagon or whatever it might be. But the holes in the device are not big enough to let immune cells in. So in effect, the device could sense glucose, put out insulin, but because immune cells can't get into the device, you wouldn't need the immunosuppressive medications that you often have to take with any other kind of transplant. And the other benefit or kind of a good concept with type 1 diabetes is that these islet cells actually don't need to be in the pancreas. It just kind of so happens to be where they, came out with Mother Nature. They just need a blood supply. So if you can encapsulate these islets, what we're doing in this study that I'll show you is we're actually just implanting these little encapsulation devices right under the skin, which is a much easier procedure than a whole pancreas transplant or something like that. So the concept is easily transplanting cells, protecting them so you don't need immunosuppressive therapy, and that would be a cure if we could get it to work. So what are we doing? We've been doing this study for actually a couple years now. And we're planning some of these larger devices and some of these smaller devices, and I'll explain why. But these are what the devices actually look like. They're made out of a sophisticated plastic or Gore-Tex. I actually have some in my bag if you guys want to look at them. But they're the larger devices, they're about the size of a credit card and about that thin. And they're very malleable and plastic, and you can move them around. And we fill them with these islet cells that come from stem cells that then can become insulin cells or beta cells that are stained here in blue. They can become alpha cells that make glucagon, which are red, and there's also islet cells that make another hormone called somatostatin, which we don't talk about. The beta cells also make amylin. So these stem cells are infused into these devices, which we're then implanting under the skin in people with type 1 diabetes. So I should mention, well, I think I'll talk about that in a second. So first of all, the cells. So these do come from stem cells, and there's a lot of controversy about what stem cells are and these kinds of things. But the idea is that when you start with a stem cell, it can become any cell in the body. It can become a skin cell up here, or a placenta cell, a muscle cell. And over decades of research, I've heard this kind of described as baking a sophisticated cake. Is that you take a cell, and on day one, you need to give it X, Y, and Z, growth factors to kind of push it down the way that you want it to go. So when I feed it this and this at these certain days, it knows that it's going down this kind of pancreatic path rather than becoming a muscle cell. And we've actually been able to get these cells to become these pancreatic precursor cells that when you implant them in a living creature, if it's a mouse or human, they continue to basically divide to become fully functional islet cells. And the great thing about stem cells is that because we can keep these alive in a lab, there's enough of these cells for basically everybody. Everybody with type 1 diabetes. So when we talk about transplanting a whole pancreas or islet cells, you're limited to somebody who might have gotten in a car accident or something like that. But this is a renewable source of cells, which is a huge breakthrough. And maybe this study will work, maybe it won't, but having these cells is a fantastic thing. So what's the device look like? I already kind of showed you a picture. This is another one. That the cells are here inside of the device, and that the glucose and oxygen can come in, the insulin can come out, but the cells basically can't penetrate. And it's just a physical barrier, just the size of the holes. If I had a glucose molecule here in my hand, an immune cell would be as big as this room. There's a big difference in the size of a glucose molecule or a T cell. So what does this look like in quote-unquote real life? So this is one of these devices that was actually put in a mouse and then cut open, and then we're looking at it under a microscope now. So all the cells are basically here in the middle, and these are cells that would become islet cells. And on either side of this is this membrane that keeps basically the cells separate from the body. And right along the membrane you see this blood vessel. So you can imagine that a glucose molecule would be coming down the blood vessel, would come across here. The islet cells could sense that the glucose is high, put out insulin, and basically you'd be treating the blood sugars, but it's kept completely separate from T cells and things that might be out here in the periphery. So this is what it looks like when it comes out of a mouse. So does it work in mice? We got to start somewhere, right? So the answer is yes. And there's a lot going on this slide, but it's a really important one, so let me kind of walk you through it. Basically what they did is that at this point they gave these mice a medication that made them diabetic, that kills their beta cells. And you can see that their blood sugars go haywire, that they go up to 500 and they stay really high. And these little circles where they give them insulin pellets to kind of just keep them alive, keep their blood sugars okay, for a certain amount of time. And here they implant just one of these small devices with the cells in the mouse. And you can see that as the cells still kind of mature, it takes a little bit of time, but eventually the blood sugars completely normalize without needing any insulin at all, with one of these cells basically just secreting insulin. And basically at the end of the study, they take out the devices and the blood sugar goes haywire again. But basically they've completely normalized these blood sugars in these mice. And the people always ask me, well, how long do these devices last? How long do you need to replace them or whatever? And the truth is we really don't know, at least in the mouse. These mice live for a year or so, and then they die for other reasons. But I always say they die with beautiful blood sugars. So anyways, so it's not time to start testing in humans. What are we doing now? We're putting in 2 of these larger devices and up to 6 of these little guys. I should note it would take probably 6 or 8 of these devices to get somebody off of insulin. So this is a very, very small dose, if you will. We're not expecting to cure anybody or anything right now. We just want to see if we can do this at all safely. And so far we have shown that we can do it safely. And we put in 4 to 6 of these little guys because we can actually take them out. We leave the bigger ones in for 2 years, make sure they can stay in for 2 years. The little ones, we might take out one at a week, one 4 weeks later, one 12 weeks later, and look at them and see if the cells are happy and healthy and what they're doing and these kinds of things as a window into what's going on in the larger devices. So what's the surgery look like? This is a surgery where we implant these little guys under the skin. And I'll just show you what one of the surgeries looks like. This is actually, I think, our 3rd patient. And the cells come in this plastic cage. It's surrounded by this pink goo. And the pink goo is just cellular media to keep the cells alive, provide them nutrients while they're being transported. And the patient's actually lying here on the table, and this is a plastic surgeon that's doing it. It's kind of funny to have endocrinologists working with plastic surgeons, but this is the skin, so this is their kind of domain. Anyways, he cuts open the bag, and he's going to drain out all this pink goo, and what's going to be left is this plastic cage here. And the plastic cage he flips open, and sitting right here is one of these devices, and he then slides onto this, what I call kind of a sophisticated spatula. And this thing goes over it like a roof, so it has the device kind of all contained in it that's going to be then put under the skin. So he makes a cut under the skin, and you can see he's retracting the skin a little bit. And then he uses a little dissector to kind of make just a little tiny tunnel right under the skin. And when these are implanted, you can still feel them. And I should say we have surfers and rock climbers and very active people in this study that, they can feel it if they push on it, but it doesn't get in the way of them doing stuff. So, and then this is the device that's actually then been deployed in that little pocket. You can see it's this plastic looking like mesh device. Up here is a loop where a suture or a stitch would be put through it, to make it stay in place. And then it's kind of sewed up. And this is a picture immediately after this person's surgery. And you can see he's actually wearing an Omnipod here. He had 2 incisions, and we had 4 of the little guys there and 2 of the larger devices kind of under his skin here. And again, the idea being that these 2 large ones would stay in for 2 years, see if they produce any insulin, what's kind of happening in the long term. But we might come back at 1 week and take out that one, 4 weeks, 12 weeks, 16 weeks, and see again how the cells are doing. It's kind of our feedback of what's going on in the larger devices. So this is what he looks like right after the surgery. He would, the whole surgery takes about 2 hours. You keep an eye on him for an hour afterwards, and then they go home. And the next day they're at work or doing whatever they need to do. So as far as surgeries go, it's not the biggest deal in the world. You never want to say surgery's easy, but certainly a lot easier than a transplant, that's for sure. So where are we 2 years later? So we've actually done 19 patients. It takes time to do these. Every time we do a patient, we take out these little devices, learn from it, and change the protocol a little bit. There's 2 places doing it right now. We're doing it here in San Diego and in Edmonton, Canada. Yeah. And it definitely appears to be safe and well tolerated. We were worried when we put these in, would there be a huge immune reaction? Would the body go nuts with these cells being reintroduced? And we don't see that. So we haven't seen any signs of rejection. We haven't seen that the body, again, is targeting these cells and going after them. And we have had positive signs when we take these out that these cells do become beta cells and are capable of producing insulin, which is a big, important step. We know that the blood supply does grow around these devices. But we want to make this, whatever we see, consistent. Because I'll tell you that sometimes we take these devices out and we get a good response, and sometimes we don't. And we're looking at different ways of making this device incorporate with the body better and things like that. And I do think it's going to take different iterations of the device to make this kind of pan out. But I'm very, very hopeful about this approach in general, that we have the cells. I think we'll figure out the device, and I think eventually we can make this work. This isn't something that is going to be in the next year or 2. This is the classic 5-10 years kind of thing. Hopefully we'll have these artificial pancreas devices that we heard about yesterday in the meantime to make it work. But this has been a really exciting thing to be a part of because I am a big believer that eventually we'll get this right. But it's happening right here in San Diego, just up the road. So I thought I should tell you guys about it. So thank you. The last thing I wanted to say is we were going to be sending out an email with this link for you locals that if you want to participate in clinical research here at UCSD, not necessarily this study, but we have other artificial pancreas studies and things like that. So this is just a screenshot. That's the link if you want to write it down now, but we'll send out an email with the link. But I'll leave this up for a second. And then our next, do you have a quick question?
Yes. How many patients have not undergone safe implantation?
Oh, they've all gone through it safely.
Oh,
yeah.
That's all. 19.
But we'll do questions, I think, at the end because I want to get through the other speakers. So if Dr. Mark Atkinson could come up here, I have his slides next. And I already introduced Mark. I'm very, very excited to hear him speak. Came here from Florida, so he might be in the running for that book, actually. But I'll pull up your slides, and away you go.
Thank you.
Yeah, thank
well,
you.
actually, the way you can tell I'm from Florida is I have both Steve and Earl's picture on my badge. Because in Florida, we vote routinely and often. So we have so you both are winners in my book. So anyway, thank you again so much for having me here. My journey with type 1 diabetes began some 34 years ago when I was a trainee, and I went to a diabetes camp and said, wow, this is something I really want to try and make a difference for. And since that time, I've been trying to find ways to cure the disease. And I know cure means different things to different individuals. I do work more than on the pancreas program, although that's my background and training in pathology. I run clinical trials trying to find cures. But they've given me a nice challenge today to kind of let you know where we are in terms of better understanding diabetes through this program that was mentioned earlier called NPOD. And what is NPOD? So NPOD is the world's essentially the largest open access repository of pancreatic tissues. It works within the organ donor network within the United States. Every year about 2.5 million people die. And then of that 2.5 million, about 100,000 become tissue donors in some form. Of that 2.5 million, about 9,000 become solid organ donors. So it's a very small percentage of the population, even though you may put it on your driver's license, that actually becomes organ donors. And of those organ donors, essentially, there's the units across the United States called organ procurement organizations. We work with everyone in the United States except Alaska and Hawaii. And if you pass away and you have diabetes, essentially 24/7, 365, we get a call. And we arrange for those organs, no matter where they are in the United States, to be shipped to Gainesville, Florida, where I'm from, where we process them and we distribute them to now over 200 projects in 19 countries around the world. It's hard to summarize what we learned in the last 10 years about NPOD, but usually when I give my long lecture, I talk about rewriting the textbooks on type 1 diabetes. And so that's what I want to hopefully give you today, is some of the fascinating things that we're learning and how they are leading to a cure. So this is my version of raising your hands. How many know this show or have seen this show? A few hands, okay. So this is a unique show on ESPN where, again, these two guys, they go along, they want to talk long and they want to talk about everything. But if they do that, they'll run out of their half-hour time too quick. So what they do is they have a way of putting a timer on things. But today I'm going to try and mimic this form and then give my form where I'm not going to be talking about sports, though. But what I am going to try and do is, again, in these 6 or so minutes that I was given, talk about these topics. And each one, I'm going to have a little timer. So hopefully, by doing this, I'll stay on time, and we'll go through, and we'll go through these topics. So the first one is that mouse type 1 diabetes is not human type 1 diabetes. And actually, one of the things I'm probably most noted on in the field is I've been the one who's been keeping track of the number of ways that you can prevent or cure diabetes in mice, which is now over 420 reported in literature. And again, you know, in humans, it's 0. But we're finding now through NPOD some of the reasons why this is, in that if you look in the pancreas of mice and humans, it's not the same. If you look at the immune response in mice and humans, it's not the same. If you look at the ability of mice in their beta cells to replicate, it's not the same. If you make a mouse fat, the beta cells replicate. If you make a mouse pregnant, the beta cells replicate. If you injure the pancreas in a mouse, the beta cells replicate. None of that happens in humans. So we've essentially spent 30 years trying to cure mice, a mouse model of diabetes that has little relevance to the disease. Not a popular subject, but again, it's something that we're learning through this program. Another thing I wanted that we've learned from NPOD, how many of you were told when you were diagnosed or there that you're here because 90% of your beta cells were destroyed, 85 or 90%? That's a kind of a routine thing. It's wrong. What we've now looked at from looking at, again, pancreases from individuals with the disease, there's a wide variation. Sometimes you'll have as little as 50% of your beta cells destroyed at onset, but what happened is that you have a lot of sick beta cells. They're there, but they just need some way of recovery. And it does come sometimes when you give insulin administration and you go into honeymoon, those sick beta cells become unsick. But again, the immune response eventually goes on to destroy them. But we think that for cure therapies, this offers hope, because if we have better ways of going in at onset, it'll have ways of helping those with the disease. Now, how many of you were told when you were diagnosed that you've lost your 90% of beta cells, and within a few weeks to months, maybe a year, all your beta cells are going to be gone? Okay, that's wrong too. We now know from studying it, and we've heard the reference to the Joslin Medalist Program repeatedly here, both through NPOD and then the Joslin Medalist Recovery Program. It turns out that about 48 Joslin medalists, the pancreas has been obtained, and I think in 46 of those 48, there's still beta cells. And we've seen that too. Now, don't get me wrong, it's not that there's enough beta cells to overcome the need for insulin replacement. But what happens is, there's been other studies on living subjects looking at C-peptide production, and again, it's true, after decades, most people still make a small amount of C-peptide. So myself and other scientists, we're trying to figure out what makes these beta cells special? Why are they not destroyed? Because if we can figure that out, that might give us ways to cure, and it offers hope for regeneration and replication therapies. Another thing that we're learning about type 1 diabetes through the study of the pancreas is that it goes in twists and turns. Again, there's common dogma to think that you start life with 100% beta cells and you have this gradual loss, you hit that 90%, and that's when you develop disease. That's not true. It turns out that it looks like, through studies of pancreas, that it's like other autoimmune diseases. If you have friends that have multiple sclerosis, rheumatoid arthritis, where they go through exacerbations and remissions, bad joints and then recovery. From our studies in the period prior to disease onset, it looks like the immune response that destroys the beta cells kind of comes in waves, in and out. And so again, this is going to offer new information for roads for prevention. And again, if we can figure out what the body does to try it when it shuts off, that'll help us in terms of providing better cures. Here's another one. How many people were told that when they were diagnosed that it's a virus? Yeah. Well, no virus yet. So and this is not, again, I'm not mocking here. These are advances. It's overturning long-term dogmas that have just existed in the field and might explain why progress has been slow. But there's probably no other dogma in existence more that type 1 diabetes is caused by a virus. And Dr. Von Heerath and I have been part of a 15-member group worldwide that has been the most exhaustive effort trying to find, through studies of pancreas, this virus. And we haven't found it yet. Now, I'm not saying it doesn't exist, but it's becoming more difficult to see a role for viruses in type 1 diabetes. Another thing is disease heterogeneity. We're learning on this. And just as it's been said at this meeting, no two patients are alike. In some ways, from a pathologist's perspective, no two pancreases from an individual with type 1 diabetes are alike. And this is so obvious in that how can you compare, say, that diabetes in a 1-year-old is the same as a 10-year-old, is the same as a 25-year-old, is the same as somebody diagnosed with type 1 diabetes at 70 years of age. We are now beginning to understand through studies of the pancreas that different mechanisms are in play or appear to be in play in terms of the development of disease. A lot of it has to do with genetics. If you have a large genetic susceptibility or gene profile, you'll probably develop the disease earlier, where if you're diagnosed after the age of 40, you probably have less genetic susceptibility. But I think one of the things that we're going to hopefully lead to changing thought is that there's great disease heterogeneity. And when we refer to type 1 diabetes, we're actually referring to a cluster of diseases that all require insulin replacement. Another dogma that's been interesting to see is that for years I've been on grant review panels and I've been in sections, and we tend to separate the sheep from the goats. And you have the type 1 diabetes and the type 2 diabetes. And one of the things that we're finding, again, from studies of the pancreas is that many of the mechanisms that are thought to develop type 2 diabetes are actually in play in terms of type 1 disease. And this has dramatic implications. When one of the workshops here yesterday, they were talking about using GLP-1 or incretin molecules in treatment. These may actually come into play and be used because we were wrong. The community of scientists was wrong. There's a lot of mechanisms that appear to be involved in the development of type 2 diabetes that are in play at type 1. Another thing is beta cell regeneration. We're learning a lot now, and again, the mice unfortunately led us astray, and you probably saw a lot of new articles that talked about cures on the rise, and again, the infamous 3 to 5 year rule. And these were mostly studied in animals who had these tremendous ability to replicate. But beta cell regeneration or replication does occur. It just occurs very much early in life, meaning within the first year of life, your insulin-producing cells, the beta cells, they dramatically amplify and replicate. It happens till about 4 years of age. Then the process really, really slows down, and we believe you essentially have the number of beta cells you have for life by the age of 4. So what we're doing is to try and find out what makes those young beta cells young and develop drugs that you could use to try and replicate them in later life. Another thing, and I just got 2 more left, this one is, it kind of came out of interesting. We've noticed this phenomenon that there's drugs that are used in cancer therapy, and you probably turn on ads or you've heard about this revolution in cancer treatment called immunotherapy. And what's been found is that there's certain classes of those drugs that when you treat somebody for the cancer, that within a month to 3 months, they developed what essentially is type 1 diabetes. And so we've been looking at NPOD tissues and finding out that the molecule that these cancer drugs attack is actually present in the immune cells in the pancreas. And we're thinking we're going to get really some really important clues on how type 1 diabetes develops. And again, from the other diseases, which is, I think, an important lesson. Another thing, and this is, again, in homage to our Steve, is size does matter. And that here's another phenomenon that actually we were about 4 years into the NPOD study, and my organ recovery people kept saying, you know, these type 1 pancreases, they're smaller. And we looked, and this was reported in the literature about 40 years ago with a very small study at autopsy, but it's true. At the time of disease onset, if you have type 1 diabetes, when you're symptomatic onset, your pancreas is about 25 to 35% smaller, and then within a year of diagnosis, if you have type 1 diabetes, your pancreas is about 40 to 50% smaller for somebody of same age in BMI. And here's the situation here where we're just showing that. Where again, two individuals, 13, 14 years of age, same BMI, and you can see the weight of the type 1 pancreas on the top is half that. And so we're trying to actually figure out, and we've identified NPOD, the importance and potential impact of what we call the exocrine pancreas, that 98% that's not involved in hormones and insulin production, how it may impact diabetes. And again, this is something that is not seen in mice. So just final words in sum. I would say that one of the major reasons that we haven't found a way to have a biological cure for diabetes is that we approach the question without having an adequate understanding of how the disease develops. We stopped in the 1970s, in the early 80s, a wide practice of autopsies, which I know is an uncomfortable word, but and we used animal models, and with that, I think we made a mistake. And so my hope is that through having human tissues now, instead of humans, we'll have a better road forward. We are making profound progress on that goal. These things I've talked about are changing the way that we do clinical trials now for type 1 prevention and reversal, and with all of this, there's reason to be optimistic for the future. Thank you.
All right, I'm going to introduce Matthias real quick, and since I've known Matthias for a while, I want to give you a little bit of background. So when I went to medical school, I went to Boston University, which was a great school, but at the time it was the most expensive school. It was about $50,000 to go per year, and then I had to live on top of that. So I came out of medical school with this big debt, and I decided I should go into cardiology because that made more money and I could pay off this debt a lot quicker. And then I met Steve during my residency, and he was like, what are you thinking? A cardiologist, you're type 1, you should be an endocrinologist. And I said, okay, you're right, I should definitely do that. So I changed my mind, and I decided to apply for my Endocrinology Fellowship, but I literally missed the deadline by 1 day. So I had this extra year that I didn't know what to do with, because before I could apply again. And Steve said, well, I know this guy, Matthias, who works in a lab down the road, and why don't you go and work with him in his lab? And it was a fantastic experience. I was definitely a fish out of water when I first got there. But I think after working there, I learned how to kind of talk to people like Matthias and Mark and learned a ton. And so I'm glad to hear you speak and excited to hear it. So come on up.
Thank you for the nice introduction. And Mark, thank you for setting the stage so well of what we have learned from the human disease. And I cannot underline even more than Mark how important that has been, also for setting the stage to properly deploy therapies. And in the next couple of minutes, I want to give you an overview of what I think where therapies should be going. Since I work for Novo Nordisk, as a disclaimer, this is not a Novo Nordisk-centric view. I will tell you what we do for trials, but there's many other things out there, and I try to give you a very balanced overview of what I'm thinking about this field. I think in terms of the destruction of the islets, and I just put this up, you obviously all know about the human pancreas. There's some use for mouse models where we can learn things. And you see this a bit on the right-hand side, where this looks like a swarm of little green ants. And we can really see how the cells of the immune system could potentially attack the islets. And these are the big green blobs in this image. And what we have learned from these studies is that this is a very fluid system. It alludes to what Mark was saying, that probably the disease, as it evolves, from what we can gather from the pre-diabetic phase in type 1 diabetes, comes in waves or relapsing, remitting. Not unlike certain forms of MS and actually many autoimmune diseases where you can have flares and then a reset and a flare and a reset. And probably the system holds itself pretty steadily for quite some time till it breaks down. So that some of these things we can see in the mice. We can also see how the cells get in there and how they access the islets. These type of things give us some important clues still how this might work in humans and how the main cells that we find in islets, these are CD8 likely killer cells as we know them, how they get there and what damage they can do to beta cells. What are the critical gaps that we face in terms of better treating or ultimately completely preventing the disease? Mark spoke, and this is in the upper left-hand panel, about understanding the pathology. I think understanding pathology actually for any disease is going to be critical. And we have been doing this together with Mark, and it's something that will teach us ultimately, hopefully, how the disease evolves and what we can do about it. What we also have learned, if you talk about the encapsulation, and Jeremy gave you a very good overview where Biosite is right now, we still need to improve on the capsules. There is certainly a matter that we have to keep the immune system out, but we also need to keep nutrients and a good flow between the beta cells and the blood system going so that the glucose levels and the insulin secretions are most fluidly read. I think we still have a fair amount of way to go there in terms of achieving this. We have to improve the capsules. We probably have to improve the location of the capsules, where we put them, and the thickness of the capsules to have this optimal crosstalk. But it is very commendable. We are getting there, and it is possible to make reasonably functional beta cells from stem cells at this point, which people wouldn't have thought that would be possible maybe 10 years or so ago. And that hopefully will solve the issue of having enough beta cells to supply. But we have to keep in mind the beta cells that will go in, they're not your own beta cells if they come from stem cells, and they have to somehow be protected from allorecognition of the immune system, just like any other organ transplant. We have to have many more trials. I think pharma industry should play a bigger role in that than they do right now. The trials are expensive. If you do them right and at the correct size, I think our trial cost about $35 million in combination therapies in adults because you need many people enrolled. But we have to do many more of those. We have to learn what drugs are doing in after onset of diabetes in prevention. And then some theme that I find quite interesting, there's an ever blurry line between type 1 and type 2 diabetes. We really need to start sorting this out better. We also need to sort out better who is particularly prone to complications and who is not. I've been trying to advocate this also in the large pharma company I work for. That's still, I should say, work in progress. We need biomarkers. we need to use these big trials to understand who is prone to cardiovascular disease, not only type 1, also type 2 diabetes, who is prone to kidney disease, who is prone to eye disease, so we can more targetedly help all of you patients to prevent these side effects. And that's something we should do definitely more of. Also in the big insulin and GLP-1 trials and so forth, I think we can learn a great deal about the disease. And as Mark already alluded, it's not a one glove fits all. There's going to be differences in progression and so forth. And I think in the next decade, we can progress more towards what you would call somewhat individualized treatment or medicine. I think there's great hope for that. I think the pharma companies also realizing more and more that that is needed. And I have great hope that we can advocate this also inside the companies to steer the boat in the right direction. So how does the situation look in terms of type 1 diabetes and where you could intervene? There are several things that are actually quite important to realize. Mark already spoke about this. The dogma that all beta cells are lost at diagnosis is not correct. And the other dogma that they go down linearly and that at the time of late-stage prevention, all beta cells might already be gone, that's probably also not correct. That's good, because it means there is beta cell function to recover. And some of you who know the immune therapy trials in type 1 know that often surprisingly rapidly, at least in some patients, there's a regain of beta cell function with immune modulators. And that means the beta cells are still there, they have an impairment of function, and we can somehow resuscitate them. And that's good. That's good for late-stage prevention, where TrialNet is very active with various trials. It's also good for recent onset trials. And these trials can be run not only in children, they can also be run in adults. And probably even more so, some of these trials could probably be run even further out than actually I have tried to get the pointer going. Probably not going to work. Let me see that I can do it like this. So they can even be run further out in this area here, where if there are still some beta cells left. And that's hopeful for opening the trial landscape and having more patients being enrolled. And particularly this area here, just prior to onset of diabetes, if this is a relapsing remitting process where many of the beta cells survive for a long time, that would be a good area to intervene, because imagine you could push out the diagnosis of the disease by several years. That would be a tremendous benefit. I also think about the trials in type 1 diabetes in the sense that they could affect how we transplant beta cells or stem cells that make beta cells and improve on the capsules, because if there is still some immune reactivity, let's say you have a very thin light capsule, maybe some of the milder immune therapies can prevent fibrosis and recognition of the stem cells that are in the capsule, and also help in this area, and so in a way merge these areas together. So I see a fair amount of convergence. Certainly, I think that it needs to be parallel tracked. We need to have islets and capsules. We need to have recent onset trials. We need to have prevention trials. And then we need to hone in on the area where we find the best benefit for the patients. And I think that's where this is going. Couple last words. Why has this been so difficult to find an immune therapy for type 1 diabetes? Really, the main difficulty, the way I view it, is safety. Safety of immune therapies is not an easy feat, and striking the right balance of somebody to say, yes, I want this immune therapy and this is a good risk-benefit balance is not an easy thing to strike. We, for example, know, in terms of the immune system involved in type 1 diabetes, from a pioneer in Brazil, Walter Relli, who has done non-myeloablative bone marrow transplants, an oncology protocol derived from pediatrics, that you can preserve beta cells rather well and even achieve insulin independence after onset. But the side effects are much too large. And probably the majority of patients would say, well, look, this balance is not going to work for me. I'm going to stay on insulin or GLP-1s or the regimen I have. So striking this balance is going to be an ever-ongoing challenge. So the way I see this and the way we can probably tackle this is in a way that we use combination therapies in a general sense. And we should do much more of this. We should have a maintaining component that has very little side effects, And in this case, we're working on antigenic therapies, in our case for a DNA vaccine that can be given, hopefully, to maintain the specific cells attacking the beta cells. And we should use also GLP-1 drugs. There's some evidence that as long as beta cells are there, and that then needs to be tested, of course, that could have a beneficial effect, maybe even on the immune recognition of the beta cells. Then on the other side, we often think about that we need some form of a systemic anti-inflammatory or anti-immune therapy that resets the immune system, with the thought in mind that this therapy is not going to be permanently used. Ideally, if these drugs are chosen properly, you circumvent the usual side effects from long-term immune suppression, which would be increased risk for cancers or infections. So that's where the balance comes in. So my thought is, if you induce with a systemic agent, but then if that is successful, together with something that is of lesser side effects, you leave in a maintenance therapy. It's not a concept that is entirely new. It's been used in transplantations in many cases. And even in some transplant patients is this theme of trying to taper the patients off these more immune modulatory drugs if the organ is accepted properly. So in a way, and that's also where it converges with beta cell transplants, these type of combinations probably can be fine-tuned. Is there sense in fine-tuning combinations? I would say probably yes. If you look at the learning from cancer and the oncology field, there, because the trials are shorter and the ethics are also different from diabetes, we have learned over the past 2-3 decades exquisitely well how to optimize combinations. And this is something we really have to do. And in type 1 diabetes, we have to do that. Because with an optimized combination, the cancer field has taught us we can make great strides. So what can we do? We have made, I told you about, we are trying to make an antigenic vaccine. Right now, ongoing and almost completely enrolled is a trial in adults where we use an immune modulatory drug. In this case, is anti-IL-21. It's a pleiotropic immune mediator, and a GLP-1 to having induction and then hopefully maintain some beneficial effects. It's a 4-arm trial, so we will learn what the immune modulator does alone, what the GLP-1s do alone. I think that's an important learning because we would really like to know what GLP-1 drugs do in a controlled environment in type 1 patients who still have remaining beta cell functions. And then, of course, combining them together. I think we will learn from this sometime towards the end of maybe next year or in mid of 2019, what the effect can be, and then want to build on that. Several ways to build on that. We can either move it in the prevention space. You could argue if it works exquisitely well, you could leave it after onset of diabetes. And if there's little side effects, you can also push it earlier into the prevention space. If either of these drugs have effects alone, they might also qualify to combine it with any form of capsule or islet transplant, depending how the circumstances are. So there are many options and learnings. There should be many more of these combination trials. We should be many more. They're not easy to do, and they're costly to do, but I think if we engage pharma industry even more, we can make great strides and really hone down the optimal combinations that are going to be needed. That's not going to be an easy process. It's going to be also a somewhat lengthy process, but I think it's needed to strike the right balance for all patients. That's all what I wanted to talk about, and look forward to some discussion and questions later on. Thanks very much.
Okay, and that last study is another one that we'll be doing here locally for newly diagnosed people within 20 weeks. So this is people that are just diagnosed. And I know I've already talked to a couple of you about it. The last panelist or speaker I want to bring up, and then to have the panel come up, I already introduced David Winkler, who's going to tell us about the DRC, the Diabetes Research Connection.
In the interest of full disclosure, I have to tell you that I'm a wannabe scientist who ended up becoming a lawyer because I wasn't as smart as all these folks. But I've had type 1 diabetes since 1960, which is a little over 57 years. And I have to tell you, it's great to see all my brothers and sisters out here. And so anyway, since I've always wanted to help find a cure, I've been involved with several scientists at UCSD. And after we did a TED Talk update on type 1 research back in 2012, we talked about the fact that funding for T1D early stage research was slowing down, and we were starting to lose scientists to other areas, and they were migrating away from type 1. So what we decided to do was form a new nonprofit called the Diabetes Research Connection. We call it that because of the ability of people to connect directly to the scientists whose projects are posted on our website, but they're only put up on the website if they meet certain qualifications. Generally, they're early career scientists. Their work has to be really innovative, like out of the ballpark type of work, because of the fact that sometimes, like with Banting and Best, it took, in that case, 2 young scientists who figured out that if you grind up a dog's pancreas, you might be able to cure diabetes. No one had ever thought about anything like that before. And I'm sure you know of many discoveries where out of nowhere, like the guys in Australia with H. pylori figured out that that was what was causing stomach ulcers, and most people didn't realize that. So a lot of these young scientists have not yet been influenced by many pathways, and you're going to see some of the research that has passed by our 80-member scientific review committee that was assembled by our scientists at UCSD. I'm very proud to say that the last 2 speakers who were up here, Drs. Atkinson and Von Hereth, are on that 80-member scientific review committee. So we have the best and brightest in the United States and in Canada who are T1D research experts who peer review the research before it goes up on our website. So after the project is thoroughly vetted, folks like you get to see what's going on. And if you like, you can, this is our current homepage, although it's due to change soon, but we have a listing of all the projects that are due to be funded and ones that have already been funded. So you can see some of the past work that we've sponsored. The really interesting thing, aside from the direct connection to the researcher, is that 100% of your donations go directly to the researcher's lab if you specify it to go to that lab. You can, of course, contribute to the general fund, but if you want to make sure all your money is going to that researcher, you can do that through our website. And also what's important with this early stage research is that it enables these researchers to develop some preliminary data to show proof of a principle and then apply to JDRF or NIH. We work very closely with other organizations, ADA as well, to try to find some of these areas of science that have not yet been explored that may deserve further funding. Some of the work's already been presented at an ADA conference, and I'll be showing you that in a second. So without further ado, I'm going to show you this website, which is, as far as we know, the first one to be developed to crowdfund and use regular funding for a specific disease. The American Brain Foundation actually paid us to rip off our model, which we were happy to let them have. We take no proprietary rights in the model or in any of the science. We want the scientists to keep all the science. So I'm going to go through just a few of our projects very briefly. The omentum is in your abdomen. It's basically between the stomach and the liver, but it's highly vascularized. And the hope is that we can extend the life of islet transplants beyond the record of 10 years or so, because this may be a better site than in the portal vein of the liver. So this work is being done at the Diabetes Research Institute, and looks like it has some promise, and they're getting close to going into clinical trials on this. This next project being done here at the Venter Institute, you may know the Venter Institute. They were on 60 Minutes for having created the first life. They took the DNA out of a bacteria, designed new DNA, and put it into the bacteria. So this project involves taking bacterial cells that exist in our body and modifying those cells similar to the way Genentech modified E. coli to produce insulin in the mid-70s. The interesting thing here is that they're working with an immune privileged site, meaning it's not subject to alloimmunity, meaning a foreign attack, or autoimmunity, which for some reason our bodies like to destroy our own beta cells. But they have found a site below the skin which they believe if they put this modified bacterial cell in there that it may be glucose responsive and produce the appropriate amount of insulin. So if we're able to find a biologic cure, clearly we won't have to deal with all the charts and graphs and all of the regulation. It would be wonderful if there was a way to have the body take care of itself, in essence, so we didn't have to think about it. This is another interesting project. As you may or may not know, about 90% of the cell types in your body are non-human. Most people think that's crazy, but it's a fact. There's a whole department relating to the microbiome headed up by Rob Knight at UCSD. And this particular bacteria may show a correlation of the onset of type 1 diabetes. If this was shown to be the case, where the microbiome, again, all these little bugs running around inside of us, either cause or predict type 1 diabetes, it could potentially help lead to prevention of future cases. This project, also here in San Diego at Sanford Burnham, is quite remarkable. They use a zebrafish model, which is kind of cool because you can see right through the skin of the zebrafish. I've been in this laboratory and have actually seen muscle cells producing insulin. They think that there may be a way to get our own muscle cells to be glucose responsive and produce insulin. Again, this is way out of the box thinking, but apparently enough members of our scientific review committee thought that it was credible. I wanted to bring this project up because it shows that our model is working. Dr. Bresco at University of Florida, sort of following on what Dr. Matthias von Hereth was saying, is looking at regulatory T cells and trying to use a nanoparticle to perhaps stop the immune attack. If that could happen, it may work not only for those of us that hopefully still have beta cell mass, but certainly early on in the onset. Dr. Bresco's work was funded in 2015. It was the first project we funded. And at the American Diabetes Association scientific sessions in 2016, he presented his work. So we're making good progress with our research, again, because it is so thoroughly vetted. While most of our work is focused on prevention and cure, I did want you to know that, unfortunately, I had a horrendous experience at a local hospital after surgery where they forgot to give me my Lantus. I woke up at midnight with a 350 blood sugar. The nurse said, "You didn't need the Lantus because you didn't have dinner," which it's the same hospital that tried to convince me my CGM was a pump. So, and I'm sorry to tell you that there was a 10x insulin dosing error and ended up killing a patient that went into the operating room, came out, he was gone. In another case, a patient gave himself insulin prior to going in the OR because he was high, and he came out brain dead. And so you say to ourselves, many of us using CGMs, why don't they use these things in hospitals? A lot of hospitals take them away from you. What we're trying to do is to get the Joint Commission on Hospital Administration to follow on some of Earl Hirsch's work, which has focused on patient care and institutions to some extent, to try to get CGMs used not just in the operating room, but also on the floors. it's obvious what the conclusion will be, which is that glucose is a vital sign for type 1 diabetics. It's as important as knowing your heart rate and other variables, temperature and so on, that are measured. So while we're waiting for this ultimate cure, at least an artificial pancreas in the interim, we've got to take really good care of ourselves. And I would just warn all of you, if you haven't had the experience of being in the hospital as a type 1, you've got to have an advocate and you've got to have your blood sugars checked regularly because of some of the examples I just gave you. So with this trial, which is ongoing right now, we will have the data which I think will prove the obvious and then hopefully change procedures in the hospital. I do hope you visit our website because we not only present news that we're generating, but also T1D news across the globe, providing a lot of updates on what's happening in the field. So you might want to check out our news. Unfortunately, Kelly Close isn't here today, but I encourage you to go to her website, Diatribe, where you can get a lot of current news. TCOYD has a lot of current news, so I don't need to tell all of you who are here to stay well informed, but this is one of the places where you can do it on our website. And with that, I would like to thank Steve and Jeremy and everyone else here for putting on a great show, and it's been a wonderful weekend.
All right, one of the ways I think you can maintain credibility in the field is not by putting dates on things. And in that, again, and I actually want to write an editorial on this for a major medical journal, and the title is kind of striking. I'm going to call it Type 1 Diabetes Cure Mongering. The reason is in my experience, again, it's hard for me to imagine a disease-associated group that's been maybe more abused or certainly near the top in terms of cures around the corner. And again, we went through a recent history again in a few months back where an institution said they renounced a $50 million gift and said they were going to cure diabetes in 5, at most 6 years. If I had a cure today, if Matthias or I or anybody had something, by the time it takes to go through the clinical trial system, that takes 5 years itself. So I can be real optimistic and say that I think within 10 years, my hope is that we have a menu of options. So if you have diabetes and whatever, all of the AP systems are out there and you're comfortable with that, that's what it'll be. If you want to try stem cells in your candidate, that would be. If you want to try the pharmacological route, that will be there, that we'll have options. On a 10-year horizon, I'm optimistic to see something like that, but it's going to take time.
Yeah, you have to. I can only echo what Mark said. If you consider the timelines just for developing what we've been doing, this tolerance vaccines, assuming that it's a very specific disease that destroys islets and beta cells, thinking that if you could only tolerize that part of the immune system, it would be very useful. So that's 6 years of pressure testing in preclinical development amongst hundreds of other possibilities to get you a lead. Then it's a safety trial. Then it's going to be a phase 1 trial to find the proper dosing biomarker. Then it's going to be a phase 2 trial to combine it with something. And then in the ideal case, if that works, you run a phase 3 trial. So you can put these things together and get a feeling for the right reasons. It has to take that long because we want these things to be safe and properly pressure tested. It's just, it's a long route to do it correctly and right. And that's how this is going to come. Is there hope? Absolutely. I'm very driven and hopeful. It's just not, you can unravel these things in a couple of years and say, then there's going to be the cure on the market. Yeah.
And then Isabel, and I might just have you guys introduce yourselves real quick, or if there's any comments you wanted to make.
Yeah, absolutely. So my name's, is this mic working? Okay.
Yeah.
My name's Isabel Chin, and I work at the Dietary Foundation with Kelly Close, who I know wishes she could be here so much. But I've been living with diabetes for 20 years and have recently had the great pleasure of working with the Dietary Foundation and learning so much more from all these panelists and et cetera about different cure-based therapies. And I think for me what's so surprising and hopeful, but also on the on the other hand, having to reckon with and challenge sort of this narrative that I've heard for so many years of all my life of the cure, and waiting for one sort of silver bullet that I'll go from having diabetes to not having diabetes, and there's going to be the cure. And I think learning so much from all of these panelists and Kelly and Adam Brown at the Dietary Foundation, that there's going to be a progression to a cure, and to think about what are the trade-offs that I'd be willing to make with different therapies. Would I be willing to do, one shot a month, and would that be considered a cure for me? And would smart insulin or artificial pancreas, if that would require a couple of surgeries, would that be what seems like a cure to me? And so I think shifting that mindset from the cure to multiple cure-based therapies, and really thinking for myself, what are the trade-offs that I'm willing to make, especially being so fortunate and being comfortable with my diabetes management right now, and having to shift to new therapies. It's exciting, and it's also a little nerve-wracking.
Okay, you want to say some words?
Sure. My name is Divya. I want to thank you so much for having us on the panel. I think it's really important in hearing all of this research to have the patient perspective and the patient advocate perspective. I'm a type 3. My younger sister has had type 1 for 10 years now. But I'm very involved in the diabetes community with close concerns now, and really, really excited to be on, such an esteemed panel. The way I see things moving forward, I think, to echo Isabel's point, is one of a lot of heterogeneity in terms of patient management even, and also potential cures, right? So it was really nice to hear about individualized medicine and personalized medicine, because I think that's where we are moving forward. For example, one patient might be willing to do islet transplantations, whereas someone who, a woman who wants to get pregnant might not. And I think that's where the word cure really means something different for every individual. And that's important to think about moving forward.
This all just reminded me, if you guys haven't seen it, you should Google or YouTube a video that Steve and I made called Diabetes in the Year 2026. And I'll give you, this is what it's going to be like when artificial pancreas rolls out and things like that. And a little spoiler alert, Steve's working at Starbucks, I'm working at Supercuts, nobody needs us anymore, everybody's blood sugars are perfect, We might not be there, but I think these AP systems will make a big difference, and we'll have things to choose from. So anybody have any questions, anything we talked about? Okay, let me go around and grab some, do you want to do it, Steve? Yeah.
We got to make them quick.
Yeah, thank you all. Wonderful. By the way, is Pamela Harris here? I have a ticket thanks to her and her mother's generosity. Please look us up over here. I remember a few years ago, in terms of gene therapy, hearing about that proton pump inhibitors might have some kind of a protective effect, and they might have something to do with turning genes on and off that might have some relationship. Is there any advance on that score, on the gene therapy end of things?
Yeah, unfortunately.
You talking about Jordache or Levi's?
Yeah. No. Yeah. So there was a study, again, that was done in mice that showed that if you give the little purple pill that you see advertised called lansoprazole, if you gave that in a incretin called sitagliptin, if you gave it to mice, it cured their diabetes. Then there was a clinical trial done to try and see if that would work in humans. It was done in Sioux Falls, South Dakota, largely, and it was shown that it didn't work, unfortunately. So, again, the thought was that the molecule that you're talking about, the lansoprazole, which is a proton pump inhibitor, you take it, again, for indigestion, that it would cause beta cell replication, but unfortunately in humans it doesn't. I'm sorry. Sure.
Question back here.
Yes, Mark, thank you for the conversation yesterday. You and I had a long talk, and it was terrific. I wanted to ask you if you are familiar with Mike German's work at UCSF and how women double the number of beta cells they have when they're pregnant. And you were talking about beta cell regeneration and that doesn't happen, but Mike German's work talks about the serotonin pathway and how we might be, if I could just get pregnant, I wouldn't have type 1 anymore.
Yeah, I know.
Special getting knocked up conference next.
Yeah, one of the things you can do to mice is well, it's there's a drug that will increase beta cells, but if you give that drug to humans, males will start producing breast milk. So we have to be careful on some of the side effects on drugs. So, but seriously on that question, Mike German's an amazingly smart person, and if we can find out how to take advantage of these serotonin receptors, there's two implications. One is, like you said, on islet cells. If we had a way to isolate islets and then in a lab take what would be, say, 100 islets and add a compound like Mike would and make those into 1,000, it would give a lot of islet cells that could be used for individuals, and the same thing could be for pig islets. And the question is and he's working on pathways to try and make this into a druggable target you could use in humans.
And there might be things we can learn from the pathology. Mm-hmm. So we recently saw that there's an enzyme that might link to these serotonin pathways that already gets lost in beta cells, in some of the beta cells in humans, long before the diabetes actually evolves. And so once we learn this, it's a very good point. We can maybe harness some of this to make more beta cells, but it's going to take some time, I think. But it's definitely a good avenue, I think.
It was mentioned before that you did research on pancreas of people with long-term diabetes after they pass away, and I was wondering, is that a beneficial thing for us to do? I hate to say that when we're talking about cures, but there's a reality here, and where the best place to do that would be.
So I greatly appreciate that question. And again, if you're interested in the program we have, it's 8 letters, JDRF-NPOD. N is in Nancy, P-O-D. It's like the iPod, but NPOD. And if you go on there, there is a spot about what you can do to help and how you can sign on to be an active member. Again, the type 1 diabetes community, actually all the diabetes community has been very much recipients of benefits from organ donor programs. I'm talking about clinical. If you think that about 1/3 of all patients who have a kidney transplant in the United States have diabetes, but yet there's never really been, at least that I'm aware of, an active program to try and bring organ donation. You get the diabetes community to do like what you're saying, to sign up for organ donation. And another thing, another dogma that's wrong, I've been given those, type 1 diabetes patients can be organ donors. There's, again, just like the old rumors, you can't get pregnant, you can be an organ donor in type 1 diabetes. Now, again, you wouldn't be a pancreas donor, but depending on the,
Mark,
except to NPOD.
Mark, two things. Afterwards, let's hook up. We can spread the word through TCOED.
Please,
thank you. Think of another good reason for Earl's sticker. I just put it on my driver's license next to my organ donation.
Oh, thank you.
There's some questions up here. Steve has the mic.
Thank you. One thing I was hoping to hear a little bit more about is I think there's some work that's gone through phase 1 already with the BCG vaccine, existing safe and effective vaccine that's moving into phase 2. That's showing some response in reestablishing glucose response?
Yeah, these are very good questions. So this is Denise Faustmann's work that she has been fostering for now many, many years. And we can say, so the main evidence for this came initially in the mice. Then she took this into humans. The evidence whether BCG vaccines, or in her case a double BCG vaccine, will preserve beta cell mass, that it still is in the pudding. What came out of this, though, in addition, is that BCG vaccines induce certain immune mediators. And one of these immune mediators, in this case TNF, tumor necrosis factor, can have effects on cells that attack beta cells by eliminating them. And there's some evidence that could be some mechanism put into place. But how selective this is, we still have to learn, because if you affect all CD8 cells in your body, you're also going to affect virus surveillance, especially for herpes viruses. So that's still in the pudding. It's an interesting approach. We actually watch this closely. There's a conference from Denise in October that I'll go to. Altogether, quite intriguing situation, but early days, let's say. But commendable that Denise has taken it so far.
think we'll do one more question, and then we want to do some important kind of wrap-up stuff and giveaways, etc.
Mine is a little bit two-partish, but a lot of the research seems like it's being done on newly diagnosed diabetics. And what about those of us who have had it for 30, 50, 60 years? And along with that, as a woman, I have cord blood from my son. Is that helpful? The reason I have it is because I was told it would be helpful, and I have a lot of it. And apparently I can only keep it until he's 18, and then it's his.
Yeah. So.
Good question. Very good question.
Yeah, I'll leave the last part for the lawyers. But for the first two things, Matt was saying, you can hit both unless somebody else on the panel wants to answer. So on the first question, I'm actually, you can see my personality. After 33 years, I just got tired of dogmas. And one of the dogma was that, like you said, on the new onset trials, that they would only benefit people usually within 3 months or 100 days of diagnosis. So my colleagues and I led a trial where we went out to 3 years after diabetes. So this is still not new onset or long-term patients, but it turned out to be a very successful trial. This is work of Mike Haller and Deschatz. And it showed that actually you can do these trials that we normally think you only do in new onset patients and people with established disease and see benefits. So we hope and we believe others are going to start doing that. And again, things like the Joslin Medalist study, I think areas that not just look at 50 years, but look at people with 10, 20, 30 years diagnosis, I think those are going to come more. On the cord blood effort, again, my group, we were the first ones to do a cord blood stem cell trial in humans. We did eventually 34 patients. And it didn't unfortunately show clinical benefit, but we hold hope that in the future, again, with the work like what Mike German's doing and others, that they're going to find ways of taking these cord blood cells and the ViaCyte areas and drive them into, if needed, into either immune cells or insulin-producing cells. So how old is your child?
He's 12.
Okay, so we have 6 years.
All right,
I'm willing to give them. I'm willing to donate them to.
Okay.
I have a lot. My doctor got 3 times what he normally gets from.
I'll trade you for a Dexcom sensor.
Yeah.
All right, I think I'm going to give our panelists a round of applause.
Contact.
Thank you very much.